Welcome to the Dr. Lexi Show, where I take pregnancy topics and break them down as best I can to help you advocate for yourself and your pregnancy. I'm Dr. Lexi, a board-certified OBGYN and maternal fetal medicine specialist, which just means a high-risk pregnancy physician. And today, we are podcasting with a very special guest, Dr. Gilberto. Welcome.
Thank you very much for having me. I'm excited to be here.
Yeah, thank you for being here. I always want to start with every guest and make sure that the listeners and people watching know what it is you do. So I'm so excited to have you today because we're going into the world of men's health a little bit. And everybody knows that I usually work with pregnant individuals, right? So can you tell us what it is that you do?
Well, as a urologist, we deal with the urinary system. So we actually take care of men and women. People just assume it's only men.
We do, yeah.
But it's the urinary system. So that's going to be the kidney, the tube that drains the urine from the kidney to the bladder, sexual function. Unfortunately, things happen after pregnancies as women get older. So we help with prolapse. So we're kind of involved in all age groups and men and women.
Okay. So tell me a little bit. We hear prolapse all the time, and a lot of patients talk to me about that. When you have someone that had a pregnancy and has prolapse, how do they know whether to go to see a urogynecologist or a urologist? Like how do they differentiate that?
Well, that's evolved over time. So I think the urogynecologist is a growing field that's really playing an important role. Because in the past, they didn't really have a lot of urogynecologists. So the urologist would get involved much more. So now it's kind of a specialty area. So certain urologists, such as myself, do prolapse. And then gynecologists who do it often will do fellowship training, urogynecology. So either or, but I think the urogynecology field has grown a lot. And they're involved in it quite a bit.
When you say you take care of men and women, so obviously my population is the pregnant population. When you say you take care of men, how is it different when a man comes to you with a urology problem versus a woman coming to you?
Well, typically, the most common reason a guy comes to us is change in urination. Yeah. So the prostate starts to get bigger and causes some issues. Yep. So we see that very commonly. When we see a woman, it's urinary problems, but like incontinence, a little different. And unfortunately can be related to, delivering a baby. And so in that sense, there are a lot, same problem, it's urine, but a different symptom.
Okay. So before we jump more into that, most individuals listening know this, and you don't know this because it's a surprise for you. I do have some questions that you don't know anything about.
Perfect.
And I say don't know anything about, meaning you don't know I'm going to ask them.
Okay.
I think you know some about them. And so before we jump into this too, so you are a urologist. So training for that was 4 years of med school. Then what was the next step?
2 years of general surgery.
Okay.
And then 4 more years of urology. So 6 years after med school.
Perfect. Okay.
It takes us long because we're a little slower.
That's what I should start telling people because it's, I think mine was 7 years after, but different path.
Yeah.
Oh man, it's so long. Is it still the same 2 and 4?
Some programs are knocking it down to 3 years of urology because part of it was research. So with money, education's expensive. So everybody's trying to figure out how to shorten it.
Okay. That's so cool. Great. Okay. So these are 10 questions surrounding pregnancy. And so I ask everybody these questions. Some people are physicians and some work in healthcare and some are just patients, right? So I always kind of want to see what people know. So as I'm trying to educate people, I can work on that. All right. Question number 1. What does the abbreviation OBGYN stand for?
Obstetrics and gynecologic treatment.
There you go. I love it. You don't get an abbreviation for urologist, do you?
Sometimes they call us GU.
Really?
Genitourinary system.
Oh man, we'll abbreviate anything in medicine, won't we?
Oh yeah.
I mean, really, it's fantastic. Okay, what do the letters MFM stand for?
MFN?
MFM.
Maternal fetal maturation. I don't know.
So close. Maternal fetal medicine.
Medicine.
Yeah.
So
that's
close.
what I do. That's why when I go to like anywhere and people say, what do you do? I don't say that because it's
nobody knows.
Nobody knows. And then if I say perinatologist, they think I say paleontologist. And I'm like...
They're giving you rocks and stuff?
Yeah. I'm like, that would be kind of cool. So then I usually go with high-risk pregnancy doctor because that,
That we know.
Yeah. All right, question number 3. How does the provider come up with the due date during a pregnancy?
I think it's based on your human gonadotrophin levels. When they start checking the HCG
Anything
the
else?
rate and time.
How many kids do you have?
Well, I have 3.
Okay.
And Prue did stop her period, but I didn't really know exactly how good that would be. Oops, you missed.
Yeah. Well, so the period and then an ultrasound.
Oh, that's right.
Yeah,
the ultrasound's very accurate.
The ultrasound's pretty good. And then they actually take the last menstrual period, look at the ultrasound, and then they use a table and say if
so it's not the blood test.
No, it's the blood. So they pee on a stick often, right? And that's more of like a yes or no. You either have the hormone in your body that you're, the pregnancy hormone in the pee, and then they do the blood test. And it's weird. That number can be so insanely high for some people and others not.
So that would be inaccurate.
It's not as accurate. Now, it should increase as you get more pregnant within the first trimester. So it helps for diagnosing ectopics sometimes or ruling them in or out or working them up. But yeah, it's the ultrasound, the last menstrual period and ultrasound. Yeah.
That makes more sense. It's very easy.
All right, question number 4. When is a pregnancy considered term?
Well, it's supposed to be a certain amount of time, but I would think if the baby's delivered, it's termed.
Do you remember if your children were born term or preterm?
Well, it's funny. The first one was term because they gave her a due date. And about a week before that, my wife started saying, I think I'm going into labor. I think she just didn't want to pass the date.
No.
So then she was close. And then the other one was like a week later from the term date they estimated it.
A week. Okay. Yep. So the due date is when you're actually 40 weeks exactly. So that's 40 weeks. And then term is anything after 37 weeks.
That makes sense. Because I have a granddaughter who was 2 months premature.
There you go. Yep. Definitely premature. Yep. Okay. Question number 5. What is a normal fetal heart rate?
About 140.
Oh, so good. Yes. 110 to 160. Perfect. Okay. Question number 6. What is antenatal testing or fetal well-being testing?
Well, one, you can do the prenatal ultrasound. There's blood tests. I think those are looking for potential anomalies. Is that the right ones?
No. But you said it with confidence, so I like it. The reason I bring this one up too is that when people get pregnant, there are so many the terminology, right? There's so many different definitions and terms. The fetal well-being testing or the monitoring is typically 3rd trimester when they put the belts around people.
So the heart rate.
Or they do an ultrasound to see if the baby's moving around and doing practice breathing. The tests that you're talking about are still things, they just have different names. And there's so many names and abbreviations that it's super confusing. Question number 7. How does an ultrasound estimate the weight of a fetus?
It's got to be, it's a calculation, probably an elliptical, go around it. And it's really cc's, but we say it's grams. That's how we do the prostate, at least.
Okay. Okay. See, so what we do is we do measurements of bones. We do an arm bone, a leg bone around the belly. So circumference around the belly, and then around the head and a side to side of the head. So we take all those measurements and put it into a certain brand name of a calculator. Hadlock is one of, it's just like, someone made up the calculation. Yeah. And then it spits out a volume and says it's this many grams.
It's impressive.
And it's not that accurate. I mean, it's kind of accurate, but the further along people get, the less accurate it is.
Wow. But further along is when you want to be accurate.
I know. And that's what makes it so confusing to people. But that's where the variability lies. And I tell people, it's like, if I'm standing up in a pair of skinny jeans, they fit fine. But if I sit down, they're a little tight, right? And so it's like as babies get bigger, they start to get a little chubbier, right? And they start to bend over. So when you're measuring, you're not as accurate as if you were standing tall.
But what about the amniotic fluid volumes? Does that play a role? Trying to guess?
Not for the growth. Okay. No. And that we measure with 4 quadrants. And I mean, what's weird with that is if the baby moves and then I measure 4 quadrants, 3 seconds later, it could be totally different. Right? So it's like, how good are we at really, I feel like with technology, it's going to be so much easier 20 years from now. We're just going to do like a quick scan head to toe and be like, here's your baby's weight.
We'll just do AI.
Yeah. No.
They won't need us.
No, I know. They have ultrasound machines like that kind of sort of now. Like they won't need us. I hope they will need us.
Always.
All right. Question number 8. What makes up amniotic fluid? And you just brought up amniotic fluid. So perfect.
Well, a part of it is urine.
Yes.
So that's important.
Yes.
As urologists, that's what we pay attention. Sometimes if the amniotic fluid is low, we're getting worried about obstructions and different things like that.
Yeah.
And then I would assume some from their, I can't remember the other part, because they're not really producing saliva.
No. They just pee and swallow their pee all day long. Yeah. Some of it early on is placental. I mean, just because, the kidneys aren't really formed yet. But
being a urologist, probably the most important is the urine.
Oh, definitely. The answer is always baby pee. When I talk to people, I'm like, it's baby pee. And that fascinates people that their babies are just peeing and swallowing. But I do tell them always, it's how we check the function of the baby kidneys. I mean, that's the biggest part. We're going to dive into that so deeply. It's going to be fun. All right. Question number 9. Who should be offered Down syndrome screening in a pregnancy?
I guess if you have a family history, but I've always avoided those kind of stuff. That's a hard one.
That's a hard one. And it's everyone. Everyone should be offered it. You don't have to. It's kind of like you and I were talking about this earlier. I had my mammogram this morning. Yay. And they ask a bunch of questions about family history, right? Like, anybody have breast cancer? How many sisters do you have? All this kind of stuff. With Down syndrome, I always like to say it's kind of like breast cancer. People think that if you don't have it in your family, that you have a lower, that you're not going to have it. You're not at risk.
But it isn't that case.
It isn't that case.
Interesting.
I know, right?
I wouldn't have thought that.
Yeah. And that's when people come in and they say, I don't need Down syndrome screening. No one in my family has it. They just need to understand, even though you don't have a family history, your risk, age-based wise, is still a certain number, because that's how we base it, is on age.
So older women that are pregnant, higher risk.
Higher risk, correct. It increases above 35 is kind of the cutoff.
Oh, wow.
35, right?
And hopefully my daughters are done having kids.
How old are your daughters?
38. No, almost 39. 35.
Okay.
And then a boy in between.
Now, he doesn't get the same label as the daughters. Advanced paternal age is 45, and sometimes people even say 50. Just not fair. It's just not fair. We're older. We're marked older earlier. And question number 10, what is considered a normal length of a cervix in pregnancy? That's a hard question, I think, because
I'll say 6 centimeters.
3 centimeters.
That's a little long. We always think in 6. That's an important number.
Oh, really?
No.
Oh. It works for me. And here's the thing that's weird with that, which you might appreciate, is that like a uterus that is non-pregnant, you can't really measure the cervix separately because you haven't really thinned out that lower uterine segment. So there's no differentiation. It's really hard to decipher where the lower part of the uterus ends and the cervix begins, because it's kind of all molded into one, I guess you could say. But as an individual is pregnant and the uterus gets longer and longer, that lower uterine segment kind of starts to define itself, and you can really see the cervix. So no one's meant to truly measure a cervix prior to 16 weeks with an ultrasound. It's just not a good measurement. I know, right? It's crazy.
And the baby has to go through that.
Yep. We just don't want it to get short or open early.
Too early, because it can't hold the baby.
That's right. Exactly. And then that's a problem. I want to go talk a little bit about, I want to go through 2 things. One is the fetal stuff, like you talked about earlier, fetal kidneys. So one of the things that I see a lot is, we call it urinary tract dilation. We used to call it pylectasis, and some people called it pelviectasis. I've heard both. But for people that are listening, watching, it's where, and you might can describe this better because the kidney is your world. I always tell people, and I show them a picture, kidney tissue generally looks fine. It's where the tube leaves the kidney to go down to the bladder. And we usually don't really see that measurement, but the diameter is larger than it should be.
Exactly right.
So then tell me from a urologist standpoint, when you see that, either if you have I know you don't see fetuses, but what are some reasons why you see that even like adults?
Well, it's all obstruction, and obstruction can be downflow. So the kidney produces the urine. Goes into a tube called the collecting system, and that's what's dilated when you see an ultrasound or a CAT scan. That takes it all the way to the bladder and then comes out of the bladder. So it's going to get dilated if it's not going where it's supposed to go. So it just starts to get bigger. So it could be there's a blockage or it's going backwards. So there's different reasons for it to be dilated. But that's what we call it hydronephrosis. Pilecaliactus is kind of saying very mild hydro. But by the time it sees us, it's hydro. Yeah. There's something going on.
Yeah. So moms that are pregnant oftentimes have mild hydronephrosis, we say, just because you have babies sitting on the ureters and if they have other complications, et cetera. So it's pretty common for us to see moms' kidneys have a little bit of hydronephrosis or a little bit of backup. Have you ever put stents in or had to deal with a pregnant individual who has such bad hydronephrosis that they required relief?
See, what happens is we get called for that a lot. And as you know, the right side's more common than the left because of the way the uterus tilts. But what happens to us by the time we get called, and the neat thing about us as urologists in pregnancy is we're just part of the team. It's the OB that's really doing everything. And once they notice some dilation and they're having severe pain, that's when we get involved. Because then you worry about, is it a kidney stone? Is it just the baby? And there are times we put stents in, and it kind of depends on when during the pregnancy you can do that, because that takes anesthesia to try to help. But a lot of times, more often, they end up with a tube outside the skin, that goes and drain and relieves it. And it's actually easier to tolerate that, even though it seems weirder because everything's internal. But that's when it's the pain that makes a factor.
Yeah. And when you put those stents in, where do they come out in the skin? On the backside?
So if we do a stent, it's all internal. So then we go in with a telescope into the bladder. We call that cystoscopy. And then you put the stent, we call it a double J because it's got a J at the top that keeps it in the kidney and then a J in the bladder. And so it's all internal. But if we have to do from the outside, that's called a nephrostomy tube. And it just goes through the skin. And now they have to take care of a bag until they deliver.
I've seen both. And as far as which one you place, does it depend on their pain or their gestation or just all in
combination?
Combo.
But a big part of it is kind of where they are, because the last thing we want to do is create preterm labor, and sometimes anesthesia at certain times can do that. So that makes a factor. If there's an infection, they're better off with the tube outside. So, because we don't want to manipulate anything because there could be a stone causing it. It could be just the uterus, but if there's an infection, they do better with the other tube. Yeah. So it kind of depends a few factors. Yeah. But what's interesting is the nephrostomy tube is weird. When you have something coming outside your body, nobody likes that, especially when they see a yellow
bag
thing.
Of urine.
That's not normal. And so they prefer the internal, but often it causes other symptoms. And so as urologists, we see how the patient's doing, because the last thing we want is put a stent in, and now the stent's causing all the symptoms and they're not better. So we kind of ad-lib it.
Interesting. Okay. And then this is a great question, I think. When you put like a percutaneous nephrostomy tube in, right, is what, okay. When do you say that it needs to come out? Like if they're pregnant, because I mean, until that pregnant uterus is relieved and the baby is delivered, they're probably going to still have pressure that could cause issues.
It's interesting. As soon as they deliver, I have them do a study, because they have a wonderful baby. They want to go home with just the baby, not anything else extra. So I'll actually do it, even though sometimes the uterus hasn't contracted it. But if there's really enough blockage that they need the tube, you'll see something more than just that. So we can get an X-ray called a nephrostogram where we see the dye, and you can kind of tell something that just kind of narrows but still goes in the bladder. That's the uterus, and it's only going to get better go home without the tube. Sometimes we'll see a stone. So now we know, okay, now we got to treat that and we can figure out what to do. So I think sooner is better. Okay. I don't make them, no.
I like it. And I always tell people the importance of drinking water during pregnancy. Do you have like a soapbox that you'd like to get on about water intake?
Well, I'm a urologist and I'm supposed to say, drink a lot of water. I'm not real good at it. Like you offered me water and I took coffee. But you really do need to. And people will ask, okay, how much should I drink? What's a good amount? And during pregnancy, a lot's going on, so you need a little extra of everything. So I base it on the color. If it's dark yellow, you didn't drink enough.
Mm-hmm.
So you want it light yellow, almost clear. So it's hard to tell somebody how much.
I like the clarity too of the pee. That's really helpful.
That's the easiest way.
Because then you know. I mean, if it's not see-through-ish, it's too dark.
It's too dark.
Okay, I like it. Okay, all right. So we went through that. I wanted to go through a little bit too about what you do and what you offer for individuals for family planning, because I know that for individuals after they have a baby and they're thinking about next baby, they're immediately getting the question of, what would you like to do for birth control? Would you like your tubes tied? All these kinds of big questions. And we still say tubes tied, but now we sometimes actually are removing the tube itself. Did you know that?
No.
Yeah. Because they found data with concerns for ovarian cancer that some of that could be actually originating from the tube as opposed to the ovary itself. So now when we sterilize or where people want that done, it's not just cutting and tying or clamping or burning the tube. It is removing. We just do a salpingectomy on both sides.
So the fimbria as well?
No, because typically those are going to be like right over the ovary. So
okay.
just the actual tube in between.
Interesting.
Yeah, just a portion of it. Take it out, remove it. Yep.
Well, with family planning, that's an operation under anesthesia.
Uh-huh. Well, I don't think a lot of people know what it entails, because I feel like when I have a couple in, the individuals, when they're discussing it, typically the male will say, she's going to do this, like get her tubes tied or whatever. And there's very rarely the discussion of the male, what his options are. And since I don't do that surgery, I don't discuss it as much, but I usually tell them, there are other things that you can do that he can proceed with. So I would love to just understand, it's a procedure, clearly. Is it just like if a female goes in and is put under anesthesia and her belly is filled with air and she has clamp, cut, tied, and having a portion of her body removed, and then, recovering from that? Is this procedure the same style or less invasive, more invasive?
It is so much less invasive.
That's what I thought. I just wanted to hear it from a urologist.
No, it's guys are kind of funny. We don't go to doctors very much. It's amazing how many patients I see. Like just before coming here, I had 3 patients come in for a vasectomy consult. I always ask, "So did you schedule this?" No, my wife did. They're not really good about being proactive about it, but it is so much less invasive. If they wanted to do something different down the road, more options. It's really pretty straightforward. It should be done probably more often than the other.
How long does the procedure take on average?
On average, 15 to 20 minutes.
Holy cow.
Under local.
Local, and it's local anesthesia.
Mm-hmm.
Local anesthesia. Okay. Just wanted everybody to hear that. Local anesthesia.
Local, quick.
Yeah. And I will tell you, and I don't do these anymore, but when we would do tubules, even we did postpartum tubules, where I trained. So if someone delivers a baby, if they wanted and they had a vaginal delivery, if they wanted their tubes tied, then you go in immediately postpartum, usually within the first 6 hours, and you make a little incision at the belly button. And that's it. That's the incision I get to find 2 tubes, cut, clamp, time, and make sure they're hemostatic and put them back down into the pelvis. That's not easy.
No, and there's things in the way.
There's things, there's bowel, there's a uterus. There are ovaries down there. I always tell people it's like working in a Coke can, right? Like a soda can at the top.
And there's a lot back here.
So I'm trying to find these teeny tiny little things in a dark cavity that just delivered a baby from the other end, right? And you get to see, you got balls in your face, right? So you can see it, right?
Yeah.
It's easy to see.
It's not hard.
Okay. I just want to put that out there for an option. And then you mentioned, I guess, because I don't know much about this, I know it's not exactly, or maybe it is in your wheelhouse and what you do. If someone did have a vasectomy and then they have a new partner down the road and they're like, I think I want to have kids again. What do they do?
Well, there's good options. And you can do what's called a vasectomy reversal, which that's a bigger deal than doing a vasectomy. That's done under a microscope, under anesthesia, but it works. But you can also do a very simple procedure, but a lot more expensive, where under local, you can do a biopsy of the testicle, retrieve sperm, But then they do in vitro fertilization. That's the expensive part. So the realities are there's always an option afterwards, after a vasectomy. Okay. We prefer people to come to us and saying that I'm 100% decided that we don't want more kids, and you feel better about that because it's supposed to be viewed as permanent.
Yeah.
But things happen.
Yeah.
But there's a lot of options.
And is it a urologist that typically, for the reversal, that's a urologist that does that for the most part, right?
I haven't done one in a long time. We have a partner that's fellowship trained in infertility.
Okay.
So the male infertility experts, that's one of their mainstay operations.
Okay.
That and varicocelectomies, to create fertility. So those are both are different things to help get somebody pregnant.
Okay.
But so now you go to a guy that's done, or a gal that's done fellowship training in that.
Got it. So for infertility, in my world, I always think of a reproductive endocrinologist and infertility specialist, and that's more for the female side of it. And then for the male side, there's a urologist that then does further training for male infertility.
It's right? A fellowship.
It's a fellowship. A year or two, something like that?
Most of them are a year.
Okay.
But sometimes 2. The extra years if somebody's doing research and going into academics.
Got it. Okay. All right. So I'm trying to think of all the things that a pregnant individual would maybe end up in your office for. We talked about the mom having like a hydronephrosis thing, and that was so helpful because I have seen so many patients with that. And unfortunately, if they have it in one pregnancy, it very frequently recurs in a future pregnancy. I don't know why. I think it's more, a lot of them don't drink a lot of water, and they probably have a reflux issue that they didn't know about. And then it kind of, rears its head.
And some, it's their habitus, their size. I've found that some very small women have a tendency to get hydronephrosis of pregnancy that's symptomatic, that's having pain. Because you can see that and not worry about it.
Yeah.
But it happens.
Yeah. So we have that one. We kind of went into a little bit about the fetus. I mean, obviously for them, we know their kidneys are working if they have good amniotic fluid. There's a couple of other little things that a fetus can get other than just the backup, kind of like we talked about, which we call in the fetal world urinary tract dilation. There are like ureteroseals. I don't see those that frequently, but I don't know from a fetal standpoint, once they deliver, I don't see them anymore. So how bad or exciting is a ureteroseel from your standpoint?
Well, what happens is you see that because prenatal ultrasound shows hydronephrosis in the fetus. Mm-hmm. So then what we've learned is they used to do in utero surgery and trying to unblock kidneys. And it's amazing how after delivery, a high percent goes away. Mm-hmm. And you don't want to do a lot. So a ureteroseel is just kind of like a cyst at the bottom of the tube that drains the urine to the bladder. And most of those don't need anything. But during pregnancy and everything's changing, it may look like that dilation. Mm-hmm. So we've learned to step back, wait, repeat x-rays in 3 months, and most of them do just fine.
Yeah. It's so hard to tell a pregnant person there's anything you see that's quote unquote abnormal, and then it's a watch and wait approach. I know it's hard because most of the time when the kidney's just a little dilated there at the ureter, I'm like, we need to give you time. I always tell them the baby needs to pee into the world as opposed to into a swimming pool, and then see if that goes away. And because it does. And then another thing that I was thinking about too, that we see sometimes, one kidney. So oftentimes I'll either diagnose a pelvic kidney because I can't see it in the right place. And then I'm like, oh, it looks like it's down in the pelvis. Or the fetus just has one kidney. And I always tell people you only need one. But what would be some things, I guess, if you have someone as an adult that only has one kidney where you're like, what are the issues that they have as an adult? Is it that exciting, or is it like, you're going to do okay?
Well, we used to always say, you're going to do okay. God gave you 2, but you can live with 1. But studies have shown that if you were born with 2, that's different than if you're born with 1. Because if you're born with 1, it changes, it adapts. So it's often much bigger than a 1 kidney would normally be with 2 people, mm-hmm. or with 2 kidneys. So it will take care of you as if you had 2. But if you lose a kidney, that's 50% less. And what we've found, studies showing that long-term high blood pressure, heart conditions, things like that, are higher risk. So now we do everything we can not to remove a kidney if we don't have to.
Does it matter if you lose a kidney because you donated it and you were healthy to start with, or you lost one due to cancer or an issue with that kidney?
Usually, if you had an issue you have other medical conditions. So you're going to do worse.
Yeah.
But somebody who donates a kidney to a loved one, friend, it's a strict criteria. They are healthy as can be. And so the chances of them having more problems down the road are less.
Got it. Okay. I like it. Okay, so you got patient kidney stuff, fetal kidney stuff, and then the partner's testicles, not kidneys. But, still, it deals with that. Okay, I got to get back into the vasectomy real quick. Vasectomy, what is it actually doing?
So the neat thing about a vasectomy is it does only one thing. It prevents one cell sperm from going to the semen that has a whole bunch of other cells. It's just one of many cells. So the only impact it has is prevents pregnancy. Now, people worry about, you hear people say blue balls or there's a backup or something, but that's not the case. So each sperm has a limited lifespan, just a little over 90 days. So it doesn't matter where it's located. It goes away, body absorbs it, and then the testicle produces another one. That's why you can reverse a vasectomy. So it has no impact on sexuality, enjoyment, pleasure. Nothing changes.
There's still ejaculate like normal. Like that
you can't even tell a change in it. People assume it's a different color. Everybody thinks sperm is white. Yeah, but it's not the case. It really has no impact on any of the other stuff.
Fascinating. Okay. So none of that. I just want any male that's watching this show, just have the conversation with your partner. And you can reverse it, which is fantastic. You can go to work the same day, maybe.
I always tell people to take the day off.
Take the day
But the
off.
next day you're up and around and back to full activity 3 days. If you're very athletic, 7 days.
Do you have to do a test after to make sure that the sperm aren't swimming and stuff?
That's very important. The thing about a vasectomy is it doesn't instantly cause infertility. It doesn't prevent pregnancy. It takes time. It could be 6-8 weeks. So it's critical after a vasectomy. We call it post-vas semen analysis. You have to give a specimen. And in the time until we show no sperm, you have to use birth control.
Yeah.
But that does take some time.
My goodness. So many things.
Yeah. I mean, sometimes I give a prescription after the vasectomy about how much more sex they have to clear the plumbing for the wife.
Oh.
Kidding.
Okay. I was like, wait, is there a certain number that just clears everything? I'm like,
well, we do say you got to get a minimum of 20.
Oh, okay.
So we do have,
that's legit.
Or 2 months, yes.
Oh.
And sometimes that's not enough. Sometimes it's perfect. But that's the quickest. So it's literally the soonest is 2 months before you don't use birth control.
Because of the lifespan of the sperm as well?
Well, because remember, we're blocking the tube in the scrotum. It goes all the way back to the bladder, to the storage tanks called the seminal vesicles.
You say, I know this. No, because I don't deal with men in medicine ever for many, many years, but I kind of recall this.
Well, there's a whole section. And so when they ejaculate after a vasectomy, live sperm's coming out. So you're clearing the plumbing.
Yeah.
Now, again, why we say 2 months or 20 is the life expectancy of the sperm eventually goes away.
Okay, I see. That is absolutely fascinating to me. And I do. The reversal part, I didn't know the reversal was, I don't want to say simple, but I didn't know it was as, I don't know the
successful?
Word. Yeah.
Well, the technique is successful. What's more important is the pregnancy rate.
Ah.
So if you do a reversal within 3 years, pregnancy rates are in the 90 percentile.
What?
If you wait 5 years, it starts to drop, maybe 70. 8 years, 50. Above 10 years, it's like 10 to 20% success rate. Because what happens is the blood, it's chromosomes. When you cut, you've changed the blood barrier and now you create antibodies against your own sperm. And so now it may not be as fertile sperm. So the time after a vasectomy determines how successful it will be.
Wow. Okay. Because I will say that the whole thing when we used to clamp, cut, tie tubes, putting them back together really wasn't a great option. I mean, very, very hard to get pregnant thereafter. And now it has become, you would just go through IVF because putting them back together it's not, the success rate is so low. And now that we're actually removing the tube itself,
impossible.
You can't stick them back together. Like when you say, 100%, you want to be certain if you change your mind later, it's not really as much of an option from the female structural method, I guess you could say.
I think the in vitro techniques have come a long ways. It's just very expensive.
Very expensive. insurance is covering it more for some people. Did you know
Really?
that? Yeah.
No.
Yeah. It's I mean, it depends, but you never know.
Yeah.
Insurance these days. Okay. So other thing I wanted to ask is if someone needs to see a urologist, how would they go about finding a urologist? Like, I feel like some people, it might be due to the insurance that they kind of get stuck. Is there like a main website you like, or like a society where you're like, this is a good place to go?
It's interesting. Our field's kind of different than a lot of fields in the sense that we deal with a lot of sensitive personal issues. And it's not like you'll call your friend and say, who's your favorite urologist? I mean, you could say, who's your favorite plastic surgeon? And they're going to tell you.
Yeah.
It's a little different. So it's really, there isn't as easy to find the urologist. A lot of times what you'll find, if it's during pregnancy, your OB. If it's for a vasectomy, often the OB make recommendations versus a site. Now, some people are really good at social media and can know how to make it so that you come to them. But overall, we're highly referred by a physician.
Yeah.
A primary care doctor, an OBGYN, things like that.
Okay. Very good. And I'll put some websites below because I know you provided a few for me so that I could kind of put some links. So we'll have those to share with individuals too. And I know you've had 2 kids.
3.
Oh my gosh, you did say 3. I left out the boy. 3.
He gets left out a lot because he moved away. He chose to go to London. So he's been there 15 years. So the girls are at least in Arizona.
Are closer. Okay. Well, are there any, I guess, things or stories you'd like to share from being on the dad side of 3 pregnancies? Because a lot of my guests are pregnant individuals currently, or they're moms. And so you're my first guest, actually second, that's a dad. So I just, any wisdom?
It's amazing. Just the whole thing. As a dad, you're scared because your wife's going through it, and often you ask certain questions on how they're doing, and it's always the wrong question, like, you idiot. So you're kind of pins and needles, even though it's not you going through all the stuff. But when that baby comes out, it is unbelievable. I mean, I'm getting goosebumps just thinking about it. It's life, and you're part of it. And then you watch your kids grow. And then the next neat thing is being a grandfather. You look at your grandchild, and then you look at your child that you can remember when they first came out, and you're like, oh, Lord, this just keeps going. This is the best thing ever. So being a parent, a grandparent, unbelievable.
I love it. And did you guys go through any complications with pregnancy, or everything was pretty good?
Oh, we were so lucky.
Nice.
Ours were really good. And my wife on the first one wanted to go all natural. And I was behind the scenes getting the nurse giving her pain medication. And then on the next one, I had to explain to her, you're married to a doctor. We have ways to make things better, easier. Epidural. And the first epidural was a disaster.
Oh, no.
It was a resident who kept missing. So then finally on the third one, we went to a private hospital because this was during residency. And it went great. So now I've told my daughters, they've all gone through epidurals.
All right. Those can be scary. I know, because you can't see what they're doing back there, and they're poking around by your back and your spine. I love it. Well, any advice or anything else that's given the pregnant individuals you've seen in your practice, and any complications? Because obviously if you're seeing them, there's something going down. But anything you want to share, or anything with those listening that are pregnant?
Well, I think the most important thing is when you're pregnant, it's now you and someone else. And that's why whenever I see somebody that's pregnant, I involve the OB/GYN, the OB so much, because you guys are really the ones that are protecting both, and so I think it's so important to follow all those things, because if you're going to have a problem, that's who's going to see it and tell us what we need, help us determine what we need to do. So every visit you can't miss, and every prenatal vitamin, folic acid is something I learned today. So important, because it's not just you anymore.
Yeah. Well, thank you for coming today. And
I enjoyed it. Thank you
for sharing your knowledge about things, especially maternal kidneys, and then going through some of the fetal stuff that we see. It's always nice to pick someone's brain.
Well, I appreciate it. I learned a lot. Did I fail on my test?
You passed with flying colors. There is no pass-fail here. Everyone passes. But no, you did great. And I think it's kind of important for the listeners too to note that some of the questions that are in my field, oftentimes OB/GYNs think that their patients know the answers to all these questions. And I want to kind of show even other physicians don't know the answers to these questions, because they're not kind of like common knowledge. And you've had children before. So you've been through this before 3 times.
Yeah.
And it's still a lot to handle. So I think that's part of what I want people to know too, is that the information I'm trying to put out there is for everybody, because it might seem simple for your OB provider and they might think you know all of these things already. Not because they are trying to not educate you, but they just assume because that's what they know every day.
When you do it every day, all day long,
yeah,
it happens to all of us.
Yeah, we get it to be our second nature and we forget that those we're talking to, it's new and people are nervous to ask questions. I'm nervous to ask questions, you know? But hey, I think that's the important part about trying to bridge the gap between individuals that are the patients and then the providers and really try to open up the questions.
Well, this is so cool the way you do this, because this is how the younger generation really learns things.
Yeah.
They don't want to be told in the office. They do want the website and something else to look up, So my wife's become the doctor all my friends call, and they used to ask me for advice, but they talk to Prue. And she looks up all this stuff. She gets all the information. So it's out there.
Yeah.
So thank you.
Yeah, of course. Absolutely. Well, I hope you guys learned some today and enjoyed the show today. And if you have any other questions or comments, please leave them below. As always, I'm Dr. Lexi, wishing you a happy and healthy pregnancy.